reiterate a few key numbers. I think we really need to understand that at least 50% of childhood blindness is treatable or preventable, i.e. avoidable. And the number we generally quote is 320,000 children are blind. It's 19% of the world's blind children. This number itself is rather outdated, as most of the data for pediatric ophthalmology in the country. And I'll talk a little bit more about the issue of data. The causes, if we take cornea, whole globe, retina, and lenticular abnormalities, that constitutes almost 85% of childhood blindness. I think Sandeep and Arnam already mentioned this, but life expectancy of a blind child is assumed to be approximately 48 years. That's a loss of 33 working years. One estimate is that it costs the Indian economy $11.1 billion. That in itself is a huge advocacy message to really push through with the government. And it's already been reiterated, I'd just like to say it again. In terms of blind person years, the magnitude of effect of childhood blindness is only second to cataract. The government has spent tons and tons of cash and effort in cataract programs across the country, but childhood blindness, unfortunately, has never gotten that kind of importance. So what do we really need for this? We need an integrated, comprehensive approach. We need prevention and health promotion, screening, diagnosis, treatment, continuous long-term care, and follow-up. And all of this has to be integrated, and the capacities of each piece of this puzzle needs to be developed for this to work properly. It has to be an interdisciplinary approach. You can't do this alone. The clinical, the surgical, the rehab, the pharmacy, opticals, lab, the works. All of it has to function together. If any piece of this puzzle is not there, you're functioning suboptimally. And you need the team approach. I think we have been fairly successful in shifting from the ophthalmologist-centric approach to a full pediatric eye care team. You do need the clinical team, you also need the non-clinical team, and you need the support services. You cannot function if your stores in charge is not giving you the IOLs you need. You can't function if your driver is not there in time to take you for a screening camp. Everybody needs to be there, and everybody needs to be trained well. In 2000, there were basically 4 training centers in the country. RP Center in Delhi, LVP, Shankara Netralaya, and Arvind. As of now, there are more than 17 training centers which offer structured pediatric ophthalmology fellowships, and I think over 30 plus pediatric ophthalmology fellowship seats every year. This itself is a huge improvement, and we need to do more on this. Over the years, pediatric ophthalmology has gained prominence as a distinct subspecialty of its own. How many trained pediatric ophthalmologists are there in this room? 1, 2, 3, 4, 5. But think back, all of you, till 2000. In the year 2000, if you ask that question in a room, how many people you'd have a lot of hands going up saying, yes, I see kids. I do glaucoma in kids. I do pediatric cornea. But who really did pediatric ophthalmology? So that itself is a big achievement for all of us here. We've also seen an evolution of the training curricula from the earlier need-based training requirements. I need to learn cataract. I can do horizontal squints. I need vertical squint training. Now at least you have 18 to 24 month structured curricula where fellows can go and come out as comprehensive pediatric ophthalmologists. We have standardized treatment protocols from abroad. We're working on developing some for our own country, which will be more socially relevant and useful to all of us. And over the years, we've also seen a little bit of a trend to actually go into the community and seek out kids needing care rather than sitting in our nice child-friendly pediatric units waiting for them to come to us. Increased government support. Over the last 3 5-year plans, it's been a 6-fold increase. I think this is a tremendous increase for ophthalmology. However, for the first time in the 11th 5-year plan, childhood blindness was specifically mentioned as a key focus area. In fact, now you actually have a specified surgical subsidy for pediatric surgeries, although the subsidy in Sarv Shiksha Abhiyan is actually more than the NPCV subsidy, and there are some discussions going on about that. In terms of the government involvement, the government has adopted the KidROP model in Karnataka, And now I've heard that in Gujarat, the NRHM is actually pumping money into rolling that out across the state of Gujarat. I won't get into the details of Kidrop. NPCB and NRHM flagship programs, eye health is included, and now luckily there's an increasing focus and acceptance of the problem and the need to do something about child eye health. Sarv Shiksha Abhiyan has a specified budget allocation for child health, and within that, child eye health is also included. A lot of our partners have been very successful in leveraging this to their benefit. We need a lot more collaboration that is actually happening right now. We have some collaborations, we have examples like Shilpa mentioned what we tried to do in Siliguri, which worked very well. But the community needs to be at the center of what we do, and then the INGOs and government agencies need to support all of those activities for us to really achieve what we are trying to do. Well, since I get paid by Orbis, I have to say something about Orbis. So, in 2002, we launched the India Childhood Blindness Initiative. At that time, the 4 training centers were the 4 pediatric ophthalmology units in the country. As of now, we have supported the development of 30 pediatric eye care hospitals and not-for-profit facilities across the country. So we've covered the country all the way from Arunachal to Gujarat, Maharashtra, from Punjab, Uttarakhand, all the way down to Kerala. You can see there's a gap there in Bihar and Jharkhand. Sorry, we'll be there soon. So, yeah. Ma'am, we'll discuss Kashmir after this. so we have covered a lot, but there's still a lot more. The WHO recommendation is that we need 1 pediatric eye care center for every 10 million population. That means in the state of Uttar Pradesh alone, you need 20. Right now we have 2, and that's it. So we're starting another one this year, and let's see where we get in the coming years. We've worked very hard with our partners to actually make these units very warm and friendly to kids so that they don't feel out of place. They actually might want to come back to see the doctor and feel happy in the hospital. Clinical outputs, these are the numbers of our 30 partners during the project periods. So it's an underestimation of the amount of work which they've actually done. But that being said, during the project periods, our 30 partners collectively screened more than 6.2 million children, treated more than 1.1 million, and did more than 86,000 surgeries. And the work is still going on. Last year, a rough estimate of our partner volumes was that our partners collectively screened about 1 million kids a year through all the various modalities. Sandeep's already enumerated a lot of this. We try to do as multi-pronged an approach as possible at all of our partners. We do screening at the hospital for all walk-ins and referrals. We do a lot of school eye screening and teachers training. We train Anganwadi workers and ASHA workers. We support the strengthening of vision centers and orient the vision technicians or ophthalmic assistants there in pediatric eye care. We do special camps for pediatrics in inaccessible areas, in vulnerable communities, children with multiple disabilities. And we're working on developing the capacity of the community-based organizations to create referral networks at the community level itself. Training has been key to all that we've done. So far, through our 3 POLTCs, that's Pediatric Ophthalmology Learning and Training Centers, we've trained 355 ophthalmic professionals, and out of those, only 70 were actually ophthalmologists. So just want to reiterate that we really focus on the entire eye care team, not just the ophthalmologist. These are the 4 unique tools that Orbis uses to train the pediatric eye care teams. We have the POLTCs, which I mentioned, Arvind, LVP, and Shankar Nitrale. We send our trainees there all from all across India as well as from Nepal. And these POLTCs also cater to training from Bangladesh, China, and Africa for Orbis partners. We have hospital-based programs where a pool of international volunteer faculty and a lot of our Indian faculty who are VFs with us, they go spend a week at the hospital and train the people there and the entire team hands-on. This used to be only ophthalmologist-based, but that too now we've changed. We take an ophthalmologist, a nurse, an anesthetist, a biomedical engineer, and an optometrist, depending on the need of the facility. Cybersight is our online platform for e-learning and e-consultation. There's a lot of content there, and you can get certifications. And our Flying Eye Hospital, here are some pictures from our program in Calcutta. I think God was happy with what we did. He gave us a rainbow on the last day. So, we also support a lot of research and publications. We do publication research through our partners, as well as helping Vision 2020 publish manuals which can be of use to the entire not-for-profit community. So, what are our key challenges? Now, this slide and the next slide will be a large overlap, but it's basically the same thing. There's a huge vacuum in terms of data on childhood blindness. We know it's a big problem, but nobody can really say how big it is with any serious confidence. Pediatric ophthalmology as a subspecialty is fairly well established now at a tertiary level, but what are we doing about it at the secondary and primary level, where the bulk of our population exists? Anesthesia services, critical to care. We have to focus on the 0 to 6 age group. So school screening is not the solution. You have to go below that and into the community to get those bilaterally blind children early so that you can actually do something with them. Human resource retention, I think I don't need to elaborate that. That's a problem for all of us across the board. And follow-up. Follow-up rates for pediatric surgical cases, I ask anybody if it's above 50% at their facility. It's something which people have struggled with, and I don't know of any valid solutions. We are starting a study, so I'll get to that in a bit. As we move forward, I would love to see all of us coming together with whatever information we have and pooling that information together for a start to get some common data sets and establishing data collection norms so that we can actually have some valid data to use for planning. We need to put our heads together and develop and pilot test models for care at the secondary and primary level for pediatrics. We need to standardize. A lot of standardization has occurred in pediatric ophthalmology curriculum. There's a WHO yellow book on that. But we need to implement that at all of our places where we're doing fellowship training. We also need to explore the idea of having modularized training programs. It's not possible for people to come from tier 2 and tier 3 cities for a year and a half to a big city and do a fellowship. It just won't work. And that has been a big roadblock to orienting general ophthalmologists to pediatric eye care. Anesthesia services. What we're trying to do now is actually at least go down to the district level where there is a general hospital and there are anesthesia services available to support our pediatric eye care units. We need to continue focusing on the 0 to 6 years age group, and a lot of the screening strategies Sandeep talked about and that all of our partners are employing are addressed specifically at this age group, which is the real vulnerable place. Retention of HRs. I don't know if anybody has an answer to that, please tell me, because every time any of our partners ask us what to do, it's a tough one, it's a tough nut to crack. And we're trying to invest more in developing training facilities across the country, because until we don't have a critical mass of HR human resources available, we'll always be running short. Follow-up compliance and a strong HMIS to track that, to track our outcomes. We're doing a lot of work. I've said our partners have operated more than 86,000 cases. Can I stand here today and tell you that all of those can actually see now? No, I can't. But we have to take that seriously and actually move towards tracking our surgical cases so that we can actually say we're doing a good, decent job of our work. And I'll just leave you with the two faces of Monica Tamang. And it's all of our jobs to get this done. It's not just those of us who are sitting here and talking. So, thank you very much.
Thank you.